welcome everybody to this 3Shape webinar together with Dr. Anthony Mack from Sydney, Australia. It's our pleasure to welcome you this late evening in Australia, of course, and this early morning in Europe, and for not to talk about the night in the US. So I'm Dr. Jan Paulix, and I will be presenting and hosting this webinar. I work with 3Shape, but I'm also a dentist doing oral surgery. And then with me I have Dr. Anthony Mack. Welcome, Anthony.
Hello, Jan. How are you?
I'm fine, thank you. How is everything down under?
Great. It's evening for us, and I guess it's morning for you, and it's maybe during the day for some people around the world as well.
Very good. We have I'm looking forward to a case presentation by you where you will take us through the journey from scanning for a single implant, doing the surgery, and also the prosthetic crown afterwards. Is this your first case, or can we find more of this somewhere else?
It's not the first case, but it's been a really wonderful journey moving into this digital workflow. It's just right now in this webinar, it's just an epitome of technology. You're in Denmark, I'm in Sydney, and people all around the world listening to us and having just an ad hoc, unrehearsed conversation about digital dentistry.
Very good. And of course you have many years of experience doing this, but this is actually our first joined webinar, so this will be the first of many, I hope. So we're going to do the case presentation, then we will have a discussion during and afterwards. Of course, I would like everybody to ask your questions through the forum, and then we will answer them as we go or afterwards. So welcome to ask your questions. And later in the end, we will also look at some new things coming from 3Shape concerning or regarding scientific information and so on.
I guess it's really great to have questions, yeah, because this is like just a really ad hoc discussion about everything related to this workflow, isn't it?
Yes. So we need your help out there to make this good as well. So let's see. So I'm actually thinking, as we have the Opera House in Sydney on the left side here, and Newhaven from Copenhagen on the right side, representing the two cities now we are working out from. I would like to make a poll first and ask a poll to everybody listening. And now on your screens you should be able to see the questions. Are you using digital technologies today for implant cases? So please everybody choose your answer, yes, no, or depends on the case. And we actually will know who is listening this morning here in Copenhagen or this evening in Australia. So we are getting a lot of answers. It's getting interesting, and we will do it just a few more seconds to see. Actually,
I can't see these answers, Jan.
Yeah, can you see those, Anthony, the answers?
No, I can't. So
No.
it's
no, it's really exciting here. I think we will stop the poll there, and I will show you the result, and for everybody else as well. So share. Yep. So now you should be able to see it on your screens. So we could actually see here that we have 33, so 1/3 is using digital today for implant, but almost half is not doing that. And then we have 17% depends on the case. So about 50-50. So this is really interesting. So we have some new beginners out there, but also a lot of experienced users as well.
And I guess this is a good case to start off with, because this is a single tooth. It's a straightforward case, and it just the result is the aim is really to achieve simplicity And for people who are not using, for those 50% who are interested in this is a perfect scenario to start on, I guess.
Very good. So let's jump into it. Anthony, you have the keyboard.
All right, let me see if I can control that. So I guess I want to present to you a case where is a single tooth implant therapy, which in general practice where I am. So I'm a private general practitioner in Sydney, Australia. Our work is basically a lot of comprehensive work. We don't place implants every single day, and this is why having this type of technology for us to help us is made I guess my workflow and our life a lot easier, and hopefully you can see this through this scenario. So I will see if my slides will move. Has that moved, Jan?
Let's say no.
Yeah, it moved.
It moved? So you should have control, and it actually moved back. So go forward again.
Okay.
Yeah. And click on the presentation, and then you should be able to control it with your arrow keys.
Yeah, I have. Can you move forward a slide for me?
Yes. So there we are.
Okay, so I guess this slide just shows that traditionally, a few years ago, we were still taking impressions. We were still doing a lot of our work with PVS or Improgum. We were still, everything had to be, we had to take a mold. But nowadays, with the technology we have today, in my practice, nearly 90% of our cases, or more than that, 95% of our cases are really digital cases where we no longer take an impression, and sometimes it's hard now to actually go back to the impression technique. But if I just briefly talk about how I compare the digital workflow and the impression, I can't seem to change those slides, Jan.
So can you click on the slide itself?
Yeah, I've clicked on it.
Yeah, and
click forward. Does that seem to work?
So let's see. And I can just do it from here then, so it's okay.
Okay,
if you just
great.
make a small nod when you're ready, I will just change the slide.
Okay, no problems. So I would really compare PVS and digital dentistry to almost like the traditional phone and nowadays the iPhone. I think digital dentistry is on the cusp of this, almost this similar to this smartphone era where they both can make a telephone call. You know, an impression can take an impression perfectly well. A phone can make a digital scanner can scan most of your general cases quite well. But it's all the apps and all the little advantages around this digital workflow which makes this type of dentistry so fun and so simple for us. So if we can move forward, Jan.
Yeah. Okay, yeah, let's see. Now if you click again, I think I gave you control now. It should work.
Okay. Yep, okay.
Yeah, now it worked, but you went backwards.
Oh.
Or is it? No, this is forward.
No.
Very good. Yeah, perfect.
So if I go back to traditional implant surgery, and you know, if I look back, what were some of the problems that I used to face? And one of the first things when I learned about implant surgery was angulation. You know, angulation is extremely difficult to get right, especially when you don't have reference points. For example, like long-spanded edentulous arches or completely edentulous, where we actually lose the anatomy of the vital structures. And if we don't if we can't get this angle right, sometimes it makes our restorative cases much more difficult, and even the outcome is more difficult. We can't visualize the final outcome beforehand until we've placed the implants. You know, and I used to, when I first started doing surgery, I used to take a lot of x-rays to check my pilot drills. I used to take an x-ray of my pilot drill, make sure that I haven't, I've got the right angle, I haven't pranged the adjacent teeth. You know, in a lot of the cases where we would used to have to raise a flap or use a delayed approach where we take the tooth out and then we would wait for healing because we're worried that with an immediate extraction, it's very easy for the implant to move during insertion. So all these are traditional problems that we used to have. But just click. And the research also shows that in comparison to sort of freehand surgery, the implementation of a computer-generated surgical guide significantly reduces the chance of error. So basically, through the research, it shows that we are getting more accurate placement of our implants compared to if we're just doing a freehand. So we're comparing if we place an implant freehand, just looking at our screen where the CBCT is compared to using a guided surgery, we're sure to say that we can be more accurate. Now, this is what we call in our practice the digital workflow for implant restorations. So we would take a diagnostic CBCT. We will also do an intraoral scan at that time, and we'll do a consult with the patient. And at that time, we sort of talk to them about using this digital workflow, whether the acceptance to the treatment plan, and if there were acceptance to our treatment plan, we would then fabricate and plan our surgical guide. And we would use with 3Shape Implant Studio, we're able to use a fully restorative-driven planning where we can actually mock up the tooth or use the existing tooth and use that as a guide to plan where we should place our implants on the CBCT, and then actually design the guide on our intraoral scan. So basically, for those who are not users of this workflow, we get the best of both worlds, where we can use the CBCT to check for all the surrounding pathology or areas or vital structures, and we can use the intraoral scan to design our guide, because we know that the intraoral scan is very, very accurate, and probably more accurate than compared to designing on a CBCT, because you don't have things like scatter, radiographic scatter, and hence we can marry the two up. And then once we've got the guide, we can then bring the patient back, place our implant using this approach, and then from then we either do an immediate impression or we can wait. And then we'll take our implant scan with some what we call scan markers, which are almost the same as an impression coping. And then we send that off to the technician to make a implant retained prosthesis. And at the end, we can insert this implant crown. So this is the 6 steps in our practice, how we start from finish in terms of a digital workflow. And it's not very dissimilar to an analog workflow. But it's something that for us, it's just made our life a lot easier. So advantages of guided surgery. What are some of the advantages in my hands in my practice? You know, for us as a restorative dentist, a general dentist, we usually like to treatment plan using a restoratively driven approach. And having digital technologies has allowed this, because you can actually see everything in these softwares that we're able to use today. And then we can transfer the implant fixture directly how we've planned it to the mouth using guided surgery. As I've said before, there's less chance of positional error. And most importantly, there's an option of flapless surgery, because nowadays if there's enough bone or if it's an immediate extraction, we know where we can be guided by exactly where to place the implant. We have a much more options of doing flapless surgery, which reduces the pain, the swelling, the bleeding, and all the blood supply to the soft tissues, all this for the benefit of our patient. We can also now prepare temporary restoration prior to the surgery because we know exactly where we're going to place it. And basically we get an ideal restorative-driven approach, and we can visualize the final outcome. And basically it will also save us time, and with time we save us costs. So, I mean, the four main things that I feel that guided surgery or digital workflow guided surgery helped us is it's really saved a lot of time during the surgical part. I mean, you do spend a little bit of time in the planning stages, but when you come to do the surgery, it just makes your life so much simpler. We used to do a lot of our implant surgery on a delayed approach where we would take the tooth out, the tooth that's no longer restorable, then we'll wait for bony healing, and then we'll come back in 8 weeks to take our scan and do our implant planning. But with this digital workflow, we're finding that probably it's the complete opposite, where we used to do 80% of our implant surgery from a traditional delayed approach. Now we're probably doing 80% of our surgery in an immediate protocol where we can take the tooth out, we can visualize our bone, we know where our implant is not going to move or has minimal movement during placement because of the way we've been able to guide where the implant goes. Look, traditionally this type of workflow was really for the real gifted surgeons, and with technology it's allowed us, it made it simpler for us, and you still need to have good training for implant dentistry, and nothing's going to replace didactic training, but it's made in our life, in our practice, basically the surgery much more predictable and the result much more predictable.
A clinical question there. When you're extracting a tooth normally and you want to insert an implant, you can almost feel how it's sliding down the old alveoli and it doesn't follow the path you actually wanted it to go. What is your experience about that? How much easier is it with the guide? Does it follow the guide or does it still follow the bone?
Look, this is just from experience from us using guided surgery for the last, 18 months, 2 years, where we've gone completely guided. Every single implant's guided. And we've found that it is so much better with guided surgery because once you've created that osteotomy site and you've created right depth, the implant, we're using an internal and we're using a tapered implant most of the time, we're able to follow that osteotomy site that much better. And we find that it does follow it pretty good, almost to the T in terms of, look, we're not looking at microns here, okay? We're talking about to the millimeter. We're finding that an immediate approach compared to a freehand approach is much better. And we're getting implants placed into the position we want using this help.
Very good.
So let's move on. So let's talk about this case. This case I wanted to share with you. Oh, I need to go back. And this case is a patient of mine, a regular patient of mine. Her name is Ada. She's 76 years old. She had a long history of some mobility around the tooth 4-4 and everything else. She had no other mobility anywhere else. The tooth was slightly displaced buccally. She had some crowning. She grew up in the area in the times where there was a lot of extractions for orthodontics, and obviously she still had a lot of relapse and crowning. So this 4-4 was slightly displaced buccally, which you'll see in the next slides. She's had specialist periodontal treatment in the past. And there was no other signs of periodontal disease. There was not bleeding on probing. Everything was good. But she had signs of hyperocclusion around that area. And so this 4-4, the mobility started getting worse. And she's previously had an implant with us, and we've been just watching this tooth, and she's come back for regular recalls and regular perio checks. And it ended up saying that we decided the mobility started to get worse, and we decided it's best to try to preserve the bone because she was losing bone around there. And you'll see in the following x-ray, she was starting to lose a bit of bone, that an earlier extraction and an immediate implant placement will be better than waiting for this tooth to really lose more bone to the apical third. And there was no signs of any parafunction or TMJ in the rest of the mouth. So these are her cross-sectional CP-CT. Well, I've missed a slide. If I can go back. This is her cross-sectional CBCT. You'll see that on the right of the tooth is where she's losing a little bit of bone, and then on the lingual, and then on the left-hand side, when you're looking at it, you can see she's got a very thin buccal plate. Almost, almost there's no more buccal plate, and it's partly due to the position of the tooth, and you'll see that in the intraoral scan later. So you can see this is her, we imported her CBCT onto the 3Shape Implant Studio, and you can see we can create an outline of the OPG, and we can see all the different views, the axial, the cross-sectional, and the tangential views all in one space. So the first thing we do is we scan Ada, and we scan her, and you can see that she's generally got a good dentition, signs of age. She's got a bit of recession around, but periodontium wise she was healthy. She previously had an implant, a successful implant on the tooth 1-6, and she's had that for about 9 years with me, and it's been well maintained, and there's no signs of bone loss. You can see in the lower there's a little bit of buccal recession on this 4-4 site, and a little bit of gingival inflammation, signs that this tooth was slightly mobile to function. And occlusally, you can see how this tooth is slightly displaced from this view, and this was the main cause of the mobility. And hence it was deemed to be that maybe an early extraction was most suitable. So what I wanted to do was, with this approach, we wanted to be able to place the implant on the same day. I mean, there was vital structures around there. Obviously, underneath there would be the inferior alveolar nerve and the mental foramen that we had to be careful of, where traditionally I wouldn't be game enough to do an immediate approach, just because of the vital structures, in case that there was a loss of buccal plate, or in case that the implant slid buccally during placement. Whereas now with guided surgery, I've been had the confidence to actually place this implant in an immediate approach.
Is there, let's say, a minimum of bone that you would need before you dare to do an immediate here, or are you just counting on that your more lingual placement will actually help this, and maybe some bone augmentation or something on top?
Yeah, look, traditionally I went through a diploma in implants, and we were always taught that we should try to at least have 3 millimeters apical bone away from vital structures. And so if you had 3 millimeters of apical bone and you could get good primary stability, then and where there was no other pathology, then an immediate extraction would seem to be a viable option. And in this case, where the advantage is you can see the cross-sectional views, and of that, once you import this into Implant Studio, and we did have enough bone there, so we're able to place this implant. And I actually placed this a little bit more subcrestally compared to the lingual, whereas on the x-rays it showed, because the buccal plate was actually a lot lower than the lingual plate. So we placed it in line about 1 to 2 millimeters just below the buccal plate, and that was my reference point there, because I was worried about recession during this immediate approach. And I think we got the placement. It looked a little bit deep, but I think we got a good outcome at the end. So here now you can see we've actually stitched our CBCT to our surface scan, what we call our digital intraoral scan. And you can see on the column on the right, you've got a few different colors, and you'll see that the green means that there is no discrepancy between your scan and the CBCT, and that you've got a very accurate mesh. Sometimes you will get a little bit of areas where it might be slightly yellow or slightly blue, and sometimes it's due to the scatter on your CBCT. But Jan, what would you say if you had a journal? How much green would you consider that, from a 3Shape perspective, would you consider that to be acceptable? That there is an accurate mesh of the two scans?
One of the most important things to look for is actually that the green is evenly distributed all over the jaw, so you know that it's positioned in a horizontal, let's say, and posterior anterior perfect way. because if you have a really bad CBCT, you can have a lot of other colors than green, but here we can see it that we have a perfect green distribution all over, and then we know it's not rotated, it's not angled or something else. It just follows a perfect match. And
I'm very
you see
lucky.
the blue and the and the blue and so on.
Question I asked.
Yeah.
So the blue bit was the scatter. So I think we've got
Yeah.
a good scan. So we can see that we've got a good scan and got good cross-arch stability. And most importantly, the areas where I'm going to place my guide was very green. So which is where I want it to be. So now once we've able to scan this, we can actually in the software, what I did was I extracted the tooth virtually and just cut out the tooth. And you can see here with this software, you can do that. And then you can actually plan your implant. And you can see this is where I've placed it. I've used the buccal plate as reference point, and I've placed it slightly subcrestally. And you can see that's where I wanted to place the implant, slightly lingual of where the actual tooth is sitting. We wanted to get a good occlusal screw retained crown on that, where we wanted a restorative approach. And just click to the next slide. You can see here positionally, even though it looks like it's a little bit deeper, we still had enough apical portion of the implant in good bone, and also, and I think we got a good soft tissue response afterwards. So here you can see that a view of when you're planning this implant on your implant studio screen, where you can see on the left-hand side where my implant is placed. We can take out all the CBCT so we can see whether the implant is coming through the tooth from a screw access or restorative sort of assessment. You can also see the nerve that we've marked, that my implant was away from vital structures. Now you can see that my tooth is gone, and I can see how my cylinder, my temporary or my surgical guide sleeve is going to sit. And I think this is a very important point, that we need to assess that this sleeve is not going to be in the way of adjacent teeth. I've made that mistake, a rookie mistake early on, where sometimes we used to place, when going for a fully guided approach, but because of undercuts, sometimes this sleeve can actually impinge you sitting in the guide. So it's very important to see this, that your sleeve is actually sitting into the space that you want it to. Otherwise, you will find you may have problems with it seating. And this is more a case when you have using much narrower implants, or for example, like a lateral space. Sometimes you cannot use fully guided, and you may need to just use the pilot drill to start, purely because the sleeve won't fit into that space.
But in this case today we will do a fully guided.
That's correct.
And for that we need the space for the cylinder as well.
That's correct.
Yeah, very good.
So basically you can see now we've got the CBCT in there as well. So you can see an outline of where your jaw is, your jaw scans, your tooth scans, your sleeve. You can see everything in sort of one picture. And it's all about giving us the information. If we can see it, we can plan it. And that's where the digital workflow is so advantageous, because we can see virtually everything before we actually do the surgery. And then you can see from occlusal view, my placement is slightly lingual to the position of the tooth. You can also see that my sleeve fits in that space. And nicely, so I can do a fully guided approach. In this case, we didn't raise a flap. We was completely flapless. And this is my design of my surgical guide. And you can see here, you can actually design it yourself. We place windows on the guide to make sure that it's seating properly. We want to make sure that it adapts properly. Without windows, sometimes it's difficult to assess whether the guide is actually fully seated or not. And little tips like this actually helps with getting your digital protocol or guided protocol better, I think, is having lots of little windows on the occlusal surface.
How do you check that the guide is actually going down all the way? Do you just watch it, or do you use the probe to feel the edges of the windows that it touches the teeth?
Both that I do that. And one of the things is when you're placing these implants, especially in an immediate case, or whether there was an early immediate case, sometimes these sleeves can be sitting on the tooth, on the tissues, and you actually don't know until you actually raise the flap. And this is if you decide to use a razor flap on these cases, or if you're doing it completely flapless, you may need to actually adjust a little bit of the sleeves to make sure that it's sitting down properly. But it's very important to try the guide in before you actually make an incision. So you can see here, I actually you can design bars to reinforce that area. You can see these little ad hoc sort of places where I've put 3D printed material. It basically enhances the stability of my guide, because where it connects to the bulk of the guide can be sometimes very thin. And if you don't put these bars there, it can actually fracture when you're putting pressure on it. So I actually like putting a lot of bars in my design. It's just something that I just, having stability in the guide is very important for me. So this is our 3D printed guide with the sleeve inserted, and it's really ready for the surgery. You can sterilize these materials. Some materials you can only do cold sterilization. Other printers and other companies have printable materials which you can autoclave. For example, the ones we use from the Formlabs printer, you can actually sterilize. You can actually print it. It comes out in an orange color, and as soon as you autoclave it, it turns to clear. So you know that not only is it whether it's bagged to show that it's autoclaved, but the color of the guide or the material itself will tell you whether it's been processed properly through our infection control. And you can see at this, we did the surgery, and you can see I placed our implants exactly where we've planned it to be, slightly subcrestal, and we got some good integration. And we went for a delayed restorative approach, purely because firstly it was an immediate extraction, and I was concerned about stability of the implant, but more importantly, you know, she said, look, artist said, look, I'm not fussed with going without a tooth for a little while. It's not in an area where you can see. And in those cases, we always take a conservative approach. We discuss it with the patient. And generally in our practice, we want to be conservative in terms of the loading of the implant, where the aesthetics is not a concern. And the only time we'll consider loading is when aesthetics is an issue. Or we had we wanted to sculpt the soft tissue, where there's a lot of research coming out where if you place an immediate temporary, you get a better soft tissue outcome from doing that sort of protocol. So now if I go to the restorative phase, now after healing, you can see that the gums and the soft tissue is healed really well. We haven't really lost any tissue height. We've had good adaptation, and we're ready for the prosthetic phase. And now we just need to basically scan the implant like we would scan a traditional crown. And there's a lot of studies to show in a single tooth, or maybe sometimes in a couple of implants in a short span scenario, there's a lot of research to show that this is a predictable sort of solution for us to do. Obviously, there's lots of different pieces to the puzzle. It's not just about the scanning. It's about obviously the 3D printing, whether the technician is using a good quality printer or he's actually post-processing the printed models accurately, whether he's fitting the sleeve into the right position into the model, or whether he's printing it. There's a lot of different variables to get from A to B, and this is something that you need to, or if you're wanting to do this type of workflows, have this discussion with your dental technician first, and really maybe do a test case before you jump in. You know, test the case where you, in those first few cases, you would actually take a PVS impression and then also scan it and see your results. And if you can calibrate yourself with the dental technician, you're getting a good outcome and you're getting good fits and you're getting good contact points, then you know that the system you've set up with your technician and the setup he has is a viable option, I guess. And this is something that sometimes can get misconstrued that, oh, I've got a scanner, I should be able to do it, because it also depends on the other side as well, Jan, who's actually designing it, how are they milling their product, how are they printing their model. There is a lot of pieces to the puzzle.
When you're getting your guides, where do you get the sleeves from? Do you buy them? Get the lab? Does the lab buy them, or?
No, we print our own. We started off sending it off to a dental lab to print it for us. But since we've got our own 3D printer, we've been printing it ourselves. and we had our technician actually come over to show us how to put these sleeves in, and sometimes it can be a little bit of tight, but if you get some of those implant drills and you just do some very light reaming, you can slide those sleeves in quite well, and either I do it myself or my dental team would put the sleeves in, and we would just push it in and glue it in.
Will you buy them from the same place or this manufacturer that designs
Yes.
your implants, or?
Yes, so we're using a BioHorizon implant in this case, and we bought the sleeves from BioHorizon. So we followed their fully approach. Obviously, there are third-party sleeves and drills. So very important that if you are using a third-party sleeve, you must make sure you marry that up with the drill sets, or make sure that the drill sets that is recommended, that your implant drill sets are compatible with these third-party sleeves, because the last thing you want is to get a guide back and the sleeve is not designed to fit in with the implant drills that comes with the implant company. So all this is a little information that you need to test and pick up and find out from the manufacturers to make sure that this workflow works.
And it's so important to have that discussion with your lab before you start treating the patient, because after you have scanned and so on, you cannot do anything. You have just to wait. So always talk to your lab before you actually go ahead and start with a case like this.
Yeah, discuss it with your implant companies, whether they offer these types of sleeves or whether they offer the guided surgical kit, or if they don't, whether they recommend third-party ones. Usually with the dental implant company, if they make it themselves, they'll always recommend their own sleeves. If they don't make it, then they'll probably have a company that they work closely with that will be compatible with their system. But if we move on, we can see that there's research to show that a digital implant impression offers a valid alternative to conventional impressions for single and multi-unit implant restorations. And I can see that with the speed of technology, how it's coming through, that more and more research will come, and this is just going to be, we might think and still question whether it works or not, but yeah, we might be sitting back in a couple of years' time and say, what were we talking about? Why wouldn't we even think of that? It doesn't work, and that's progress. So for our restorative phase, for this case, we used a BioHorizon scan marker, and this is something that's new to the market. And basically, for people who are using this digital workflow, they already know that the talk of libraries. Basically, when you design an implant restoration, there's a set geometry how that fits in. And traditionally, in an analog approach, we just buy the parts. But in a digital workflow, if you want a customized abutment, it needs to be designed in the software. So these little markers that we scan marry up to a specific library. And traditionally, each implant company will have a library for their own scan markers. And then there will be other third-party companies which will have a library for their own scan markers. And they probably design this with reverse engineering, where some of them may have been accredited with some implant companies. There are out there ones which may not be accredited. And this is, again, something that you need to find out whether this is suitable for you or not. But with 3Shape, what they've done is they've said, well, we want to help the people who are using this. So we want to say that we want to design one scan marker for the dentist to use, and we can collate all the libraries from all the different implant companies or the manufacturers of these scan markers, and so that you only need to use their scan marker, and you have a resource of different libraries you can use. And this is something that's coming along, and it will only get better and better, because as a dentist, where we were looking for restorative options, we sometimes have a lot of different brands of scan markers. And if your technician doesn't have the library of the scan marker that you scan with, then you're in trouble. And again, this comes down to communication with your dental technician about what laboratory software they have, what library that they have access to, so that when you so when you buy these scan markers, or what we call impression copings or digital impression copings for your implant, you must make sure that everything sort of marries together. So what we did was these little scan markers, the advantages of them that in the future that they're going to have almost like QR codes on them. You as soon as you scan them, they're going to pick up exactly the implant system. They're going to pick up exactly the platform or the connection type, and it will automatically, this data will get transferred to the technicians. And I've definitely experienced this myself where I've actually selected the wrong connection because I was in a rush when I was scanning, and I got back a crown and I tried to fit it in an implant crown, and it didn't fit. And then my first thought was my technician must have made a mistake. But in actual fact, it was me, and most of the time it's probably the clinician. We actually selected the wrong connection, and hence the technician was working off a wrong library. So nowadays, with this type of recognition, we're able to, again, sort of take that potential for error out of the equation. And these scan bodies are manufactured made of complete titanium, and they're autoclavable, so you know you can reuse them for a number of times. And I don't have the information how many times that they can be reused, Jan. You may be privy to that.
Yeah, we for the audience to know, we have a presentation about the scan bodies on our homepage, 3shape.com, but we recommend at least 100 times. And the good thing is that when you're using a non-titanium scan body, you might over-tight it, so then you actually would change the shape of the scan body itself. With titanium, you cannot do that, so it will not change shape if you autoclave it or if you tight it too hard or something else. So it's a really beneficial scan body.
And also you can see it on the X-ray, you can see the fit, because some scan bodies out there are made of a PEEK material or plastic type of material. So because that seems to scan better traditionally, but now with these ones, they seem to scan quite well. And you'll see me scan this case with this scan body. So research also, studies have shown that our patients actually prefer to have scanning. And being a user where I've used PVS impression many times, we find those difficult to take impressions, patients who are gaggers, patients who have big tongues, patients who have a lot of saliva, like, it's like a fountain. They just keep spitting out saliva. Those patients are perfect for scanning. And those ones are the ones where you really realize how beneficial it is to have an intraoral scan in your office. And for me, using this firsthand, I love it. And I love this kind of workflow. And I would only take an impression if I really felt that I wasn't getting the result I was, if I ever couldn't get the result with a digital workflow.
Would you say, Anthony, that the benefit of using the intraoral scanner is even bigger when you're doing implantology than for normal crown and bridges?
I think it's just a big picture. Yes, for implants especially, but even for crown and bridge, I'm very fastidious about my margins and isolation, and I think we follow the same protocol in terms of isolation for impressions and scanning. But definitely, because I think with the scanning, where the benefits is that you can actually capture the preoperative, the view. You can then capture the soft tissue, which I'm going to show you, and then you can capture the scan marker. So you can see everything in one scan, whereas if you did that with the impression, you sometimes have to say, oh, I have to go and because I've used a wider healing abutment, I have to use a wider impression coping. If I don't have that, I'm worried that my tissue will collapse. Whereas here, if you do this where you're just doing a cutout technique, you can actually scan the soft tissue pretty much within seconds as soon as you take the healing abutment off. And that's some of the advantages I find are much more beneficial in this workflow than anything else, Jan. And here you can see this is our preoperative. We're ready to restore. And this is our healing abutment that's in place. And you can see now that I've got good soft tissue. We haven't lost a lot of tissue. We've got good healing. And we scan this. We're doing what we call the pre-op. This is the 3Shape implant workflow, where it allows you to capture everything in one scan. So once I've scanned this, I actually just cut out the little area where the healing abutment is. And then I can scan the soft tissue. And the good thing is that I can capture this soft tissue very quickly. So I don't worry about tissue collapse anymore. And that's one of the advantages of that. So now I've captured the soft tissue, so my technician can use this to work on the emergence profile. And then if I have to put my scan marker in and I have to wait because I have to take an x-ray to check it, I don't worry about the loss of tissue or the change in tissue because I already scanned the soft tissue. And my next scan is really just a marker scan. It's just to verify exactly where the implant is. And so now then 3Shape allows me to just cut this area out, and then I just then insert my marker. I can take my x-ray to check where this is, and then you can see that I can scan this scan marker very easily. And look, I think it's the simplicity of this workflow, and all of this, you can see all this in the one scan, whereas you're locked in with the impression. Once you take it, if it's not correct, how are you you've lost that tissue. You've lost that tissue color unless you do a customized impression coping. And that sometimes for a patient who's not aesthetically conscious can just add to the cost and the time. And I'm trying to make it simple for my patients because they're 76. They don't want to open for a long period of time. They don't want me to muck around with trying it in and putting flowable and checking that I've got the correct soft tissue adaptation. Sure enough, for a front tooth, or if the patient demands that, I definitely will. But for a non-aesthetic patient who just wants a tooth, which is a lot of my demographic, this is something which I find has really made my workflow really simple. So you can see in my implant placement is perfectly centered, and I attribute this to the guided surgery, not to that I can place this implant dead center, because in an immediate extraction it's very difficult to place that dead center, and really I'm sure it can be done, and for all those experienced and gifted surgeons. But for a young dentist who's starting out, or who for us who don't do as many implants, having this help using guided surgery has been something that has been a really good saving grace for us in terms of a general practice. So now I can...
Yeah, we have a question from the audience here. Now when you're doing this immediate placement, how long do you usually wait before you take the impression and the crown?
I usually wait 8 weeks for mine. I'm conservative. I would wait 8 weeks to get good healing, and then I would then scan it, and then I've got another 3 weeks before I fit it in. So it's a turnaround of 11 weeks from the time of placement. But obviously there's different protocols. I know some other people say you can do it earlier. Other people will say later. I guess it depends on the stability of the implant and your confidence to load that, I think. I'm always urged on the conservative side, and hence that's basically our protocol. So you can see now, you can see the whole scan marker, it's inserted. We've taken an x-ray to verify that it fits. And we've scanned this now. You can see how we've taken our scan, our marker scan. You saw the soft tissue scan before, and it's all in the same scan. And we send this to our technician. So now we've finished, and you can see occlusally it's dead center. And we've captured all the scan markers so that it's easy for our technician to verify that in his CAD software. And here you can see that he's stitched the library to our scan, and then he's designed. Now he's married up his library, the 3Shape scan marker, to the implant. And then he's designed a customized abutment, a zirconia abutment on a titanium interface. And then we've used a lithium disilicate crown on top. And he's fused that with a CAD-on ceramic. Basically, he's fired that onto the zirconia, and we're able to get a nice screw-retain crown and finish. This is a zirconia abutment with a lithium disilicate crown. So this is all milled, it's all customized. He sends it off to our milling center. And then he finishes that off, and you can see that we got a decent outcome. This is his 3D model. Traditionally, he's used a Stratasys model. What we're working with the local printing company now called Asiga, and we're getting exceptional results from their printers. I've been amazed at the quality of that printer. It's such a small platform, but the quality of the print we're getting out is amazing. And so highly recommend for anyone who's local or they've got a big overseas market to look into this type of technology from Asiga.
Looking at your scan here, I could see that you used the full mouth and everything for this case, of course.
Yep.
And we have a question from the audience. What is your take on scanning just a quadrant for this kind of cases?
Look, for me, I always like to be thorough, and if I was going to take a full arch impression for implants, I would obviously scan a full mouth because it doesn't take me that much longer to give my technician more information. You know, if I can't give my technician all the information, then I can't critique his work. So if the work is not of an acceptable level that I'm happy with, if I don't give him the information, I can't expect that from him. So I think it's an expectation. So if we want to expect good laboratory work from our technician, we need to give them that information. And a full arch scan is definitely the gold standard. And I would always stick to a gold standard in terms of that. I probably wouldn't. I don't see a benefit in doing in doing a quadrant. And the only thing I would say only save me a minute or less than that between a quadrant and a full arch. When we're getting full arch scans in a minute or so, I don't see we're still faster than PVS. So I guess that's my answer to that question. And you can see now we got that crown back and we were able to fit it in. So you can see we got a perfect connection, perfect fit. And you can see that we got screw retain. We filled that up with a composite. We got a nice anatomical form. We kept the zirconia on the soft tissue, so we hopefully will get a nice soft tissue interface. And you can see the final result of this case there. We've got a post-op review where we've got a really nice outcome, you know, something that's simple, good delivery, minimal appointments for the patient, and for me it's predictable and I can control it. And because of these reasons, that's why I find this type of technology has really improved and improved my quality of dentistry, Jan. That's probably it's saved me time and it's improved my dentistry. And so that's my part. Jan, I'll let you take over.
Thank you. Let's see where we go from here. So just a quick, let's say, an input from the audience. Actually, that we have a good idea about why to scan also the full arch. Of course, it's to see the opposite side. You cannot copy let's say, the premolar from the other quadrant if you don't see it when it comes to the lab. So that's also an important step to do as well. Let's see. Let's see what we have more in questions here. Why wouldn't you choose, let's say, a single material for this crown instead of mixing them, the zirconia and the Emax?
Yeah, a single material would be, let's say, a monolithic zirconia, I would say. A monolithic zirconia is definitely a viable option. And I think the decision, what I find is that it's also dependent on the technician and his ability to give me the restoration or the aesthetics that I require. And I know I've been working with Brad from New Zealand for over a decade, and I know that he's a master of lithium disilicate. And because of that, I entrust him to give me a good aesthetic result from lithium disilicate. I don't see too much disadvantages of using this technique. If I'm happy with the monolithic zirconia as well, that's definitely a viable option. You also then have to assess the wear of the restorative material. Obviously, zirconia on the occlusion, is there wear on opposing teeth in an aged or in an adult or in sort of an older population? If there's a bit of wear, I worry about the wear against zirconia. But generally, I haven't had too much problems with this type of technique, and I actually do a lot of cases where there's monolithic zirconia just fully to the occlusion. In cases where maybe a little bit further back, where it's not in the smile line, I would probably use a monolithic material.
What we know today is that many labs, they are starting to do model-free, model-less work when it comes to single and smaller units and so on. What is your take on doing it for an implant case, for example?
Look, I think it depends on each person's comfort zone. I think it's definitely doable. I think we've always preached that you trust the CAD because the CAD software is accurate. You're only dealing with zeros and ones. Whereas when you open up with a model, and we definitely don't design our restorations and use the model for verification for the design process because we know that that's our weak link at the moment. And where the CAD is, we only really use the the model in an implant base just to double check our contact points, really. We know that the connection and the design, the model doesn't actually do anything in terms of helping with the emergence profile unless they had to layer ceramics, but in a monolithic form, yes, definitely model free is definitely a viable option. You just need to tweak. My only guess is that you'll need to tweak with your technician on the level of contact or the how tight you want that, and you need to calibrate that with him. You know, some people like tighter contacts, some people like lighter contacts. Because my technician is overseas and I have to, it's always like a 3-day turnaround, fastest 3-day turnaround. I usually like him to be slightly tighter because then I can make small adjustments in the mouth. If it's an open contact, or it's slightly open, then what will happen is that then I have to send it back, and it's compared to I use a local technician, I can get it back the next day. But I usually like it a little bit tighter. But definitely, yes, to answer the question, completely for a single tooth scenario, definitely a viable option.
Yeah. We have to continue, but I would like to use listeners to know that we actually will stay on afterwards a little time to answer some more questions. So let's see if we can move on. Yes, we can. So remember that write your questions down and we will take them afterwards and we will share the answers with you, with everybody. So when we look at this, the first question we had in our poll, I think it's time to actually answer it again and see what we have done today, if we have affected anyone. So if I just go back there and we will get the poll started again. So it's open. And now the question is, has this webinar swayed your opinion in actually doing it the digital way, or are you already doing it? So please, everybody, click the right answer that fits for you, and then we will soon see the answers. So we are getting more and more answers. Let's see. Let's wait a few more seconds. And now I think we are ready to stop, and then we can share the result with everybody. So the results, yes, more and more people are actually thinking of doing it digital now. Just a few percent still hesitating. So let's see if we can get everybody on board later. I think it can be a long evening for us, Anthony. We have to get these 4% with us. And 36% is already doing this. So we have reached a few new souls, let's say, with your presentation. And that is always nice. To actually give this a little more of a boost to everybody, I would like to inform you and present the 3Shape community. This is where you actually can log in with the help of your Communicate account password. You find it on 3shape.com. In the right corner, upper right corner, you find 3Shape community. You log in, and then you can find a lot of information, a forum where you can read and answer questions between each other, a knowledge center where you actually can see the webinars and you can see videos on how to do things and so on. A lot of testimonials, doctors talking about how they would like to see others also use the technique from 3Shape and how they have gained using it as well. And of course then all the 3Shape events and exhibitions that we are actually inside. So in here you can also see the upcoming best practice guides, and this will be actually things like you just talked about, Anthony, how you do this and how it can be done in an easy and predictable way when it comes to implant planning, when it comes to scanning for implants, when it comes to crowns and bridges, later on also for dentures and so on. So a lot of things will be presented here for everybody to take part of. So go into 3shape.com, and as you can see, there are also case studies here. So when you come to the corporate website in the top, you choose Knowledge Center, and then you can For example, see Anthony there presenting a few cases, and also some other colleagues that will talk about and present their cases.
There's
And
quite a few Australians there, Jan, so it's a good intimate relationship we have.
yes, it almost looked like an idea. Let's see. Maybe we can get some more doctors to come in with their cases, because at 3Shape we would like to share our users' work, so everybody can benefit from this growing way of working digitally today, both with scanning and of course with the softwares and everything else. So. Anthony, before we stop, actually I would like to introduce everybody to the next two webinars that we will see. Latest innovations with digital dentures, where we have our VP, Rune, that will talk about the newest ways to actually present and manufacture digital dentures, all the way from the clinic to the lab site and then back to the clinic again. Really interesting, so please tune into that. In your inboxes, you will have now a link where you actually can sign up for these webinars. Also, later on, you will hear Christopher Adamus, our Academy specialist, talking about implant libraries, the lab part of that one, which of course we have heard today is really important to get a good connection before you start scanning the patients. So with this, I would like to take the opportunity to say thank you to you, Anthony. It has been a great pleasure. And of course, this was the first time we did this, let's say, intercontinental webinar. We had a few, let's say, small issues in the beginning with clicking and so on, but I think that that this has been worked out, and it's again my pleasure to have you here. I would like to thank you very much.
Thank you,
and
Jan.
thank you to the audience. Also, let's sign up for the next webinars, and have a good evening in Australia, and have a good day in Europe. But remember, we will stay on now after this official way webinar, and we will answer your questions. So let's stop the webinar now, and we will still be here. Thank you, everybody.
Thank you, everyone. Have a good evening and good morning.
So now the official part of the webinar is done, so we can go back and answer the questions. So let's see where we are. I will just pull them up here and see, so we can read them. So we had, yes, a good question here from a colleague that asks, it can be difficult to scan the contact points, especially in a tight space. Do you, Anthony, have any tips on how we can capture this area better?
The contact point as in implants, are they referring to implants, or I think or a normal crown and bridge?
Let's talk about the implants today. So of course then you have a bigger space to do this. But I think it's really important, as we just said.
I think the solution to that is to find a scan marker which has, for those tight space, a longer scan marker. I find, I think I gave that feedback back, where if we had a narrower platform for the scan marker and making it long, having an option of short and long, it really will help, because sometimes, you know, in these cases where there's been previous bone loss, you know, your implants are usually a little bit deeper, and you've got long crown heights. And yes, I agree, sometimes scanning those tight spaces, lower anteriors, you know, tipped in molars against the premolars can be difficult to scan, especially on the lower teeth. So I hope that the companies will make a version of a long and short scan marker. I know some dental companies or third-party companies already have that, and so in those cases where I struggle with the tight space, I would use those longer scan markers. And if it all else fails, then you need to maybe go back to an impression coping. That will be the last resort. But that's how they work as well. In the impression coping, you also need to have a long one if you got a tight space as well.
Very good. And actually, you showed the best way to scan the contact points in your presentation. Is actually to scan it as a pre-scan. So then you have the contact points, and we don't have to scan them anywhere else later on. So we start with the pre-scan, then you scan the emergence profile, and then you put the scan body in and scan just the position of that one. So the contact points will come from the first scan when there was no scan body in there.
Yeah, if you're looking at that workflow, which is you already got the contact point, the scan markers only purely you need to scan enough for them to reference or stitch it to the library. Your emergence profile scan, your pre-op scan already has the contact points. Yeah.
Yep. Very good. Let's see. We have a question about if you are cementing the crown to the abutment or if the lab is doing that for you.
The lab is doing that. So he actually doesn't cement it. He fires it on with ceramic from Ivory called Cadon. So it's almost like a luting ceramic. So if you use that, they actually fuse your lithium disilicate to the zirconia. And so it becomes a one piece. It's almost like a layered zirconia crown, if you imagine, to it. And so we get it back as a one piece sort of scenario. Very rarely will we cement unless if we were going for screw retain, we would never cement it ourselves. We will always get the lab to do it. It's when we have to use a cement on option, which is nowadays on a rarity, then yes, we would obviously have to cement that in the mouth. But generally, with the abutment and crown, we would like the labs to finish it off so we know there's no discrepancy whether it fits or not.
We have a question about the merging of the two scans. So we could see here in your presentation that this alignment of the intraoral scan to the CBCT was done automatically in the software. But what is your protocol if it doesn't actually align automatically?
I find that, basically if it doesn't align automatically, then you would need to select three points in the 3Shape software. Traditionally, in the older versions, we usually find distinct landmarks where there's change in contours, like incisal edges or cusp tips and things like that. But what I've learned with the 3Shape Implant Studio is that you can just select any surface on that tooth, and it seems to marry up quite well. So I find that we haven't had much with the newer version of the software. We've had very little trouble with actually the stitching of the scan. I think plotting plotting the line, the OPG line in the CBCT, that part is important. I think in terms of, I'm not sure if that helps. If you get a good line there, you get a better stitch to it.
Very good. Perfect. Let's see if we have any more questions. So someone, let's see, that person left the webinar, so we don't have to answer that. They wanted to know your technician's name, but we can say that many technicians can of course do this, and it's a benefit if they use 3Shape software, of course. So let's don't go into that. We have someone congratulating you on your wedding anniversary today. So congratulations, Anthony, and your wife as well.
Yes, I have to. I think I have to get home and make sure that I'm a good boy for tonight.
So we really appreciate you taking your time and not being at home celebrating yet. So the last question that we have is that do you ever do an immediate temporary in PMMA for example, for anteriors?
Yes,
and
so
if you do you utilize the direct protocol, or do you have the lab to do it for you?
Usually I get my lab to do it. So basically we'll design it and then because he will probably do the mock-up, so I will work with him to do the mock-up. So once he's mocked it up, then usually I then send the files to him and say this is where we're placing implants, and then he will design the temporary for me. Traditionally, we used to mill them out. Nowadays, if we can actually print them out with some printable resins, so we're doing a lot more 3D printing now in terms of, and we're finding really great results with this because it's a lot easier to reline. If you're using PMMA, Sometimes if you want to create a bit more soft tissue adaptation, depending on your site, which you can't get from your initial scan, especially, for example, like an immediate extraction site, you can actually go and touch it up and modify your emergence profile with some flowable resin. And this works much better if you printed the temporary rather than mill the PMMA, because obviously you'll have trouble bonding to the PMMA with flowable composite resin.
Really interesting way. And actually we have one more question here. We talked about the model-less and you printed a model because you wanted to follow your standard. But what do you use the printed cast for? Is it to check the contact points or the occlusion, or is it just to hold the crown in position when it arrives in your clinic?
A bit of both. I just like to, there is a level of accuracy to these printers, through these printed models. We usually like to verify to fit the shape of it, whether it fits. I would like to see it on the model, because when you get back just the crown, you can't actually see whether the shape of that crown is in line with the rest of the teeth, because your patient's not there. So when I have it on the model, I mean, might go back to our old school technique where we like to have a look at the lab job on the cast, so we know that, okay, well, firstly, the job's correct, it's on the right tooth, we haven't got another, they didn't send the wrong job back. Secondly, we can just check that, okay, well, it sits on the model well, and the technician hasn't made a mistake, and it fits onto the model nicely, and the contacts are good. And so we can also verify if something goes wrong. Let's say if something goes wrong, whether it was the technician's fault in the scanning, or whether my fault in the scanning, or whether it was the printed model, or whether it was a blatant error, where if it's an open contact point on a model, and it's an open contact point in the mouth, then more than likely it's a design fault,
Mm-hmm. We talked about doing one piece, let's say in a monolithic material for zirconia. But what about monolithic Emax?
Yeah, look, I have no problems with that. It's just I just find you can do that. It's just I think from a aesthetic point of view, if I was doing monolithic Emax, I find you need to get a fairly opaque shade, because obviously the light, if you use a translucent shade, it'll penetrate through and your restoration will look grey. If you have a very opaque shade, because you've got quite a big bulk of the restoration, then obviously you may not get the natural translucency of the tooth. So I find with the two-step where you use the zirconia abutment and the lithium, I get sort of the best of both worlds. But yes, definitely a monolithic lithium disilicate is definitely an option. Obviously, if we had the choice, there's no, if it was a non-functional or non-aesthetic case, I probably would go for a zirconia. Yeah, but yes, that is a possibility. Yeah.
And that was the last question. So again, thank you, Anthony. Give our regards to your wife. Have a nice evening. And thank you from Copenhagen.
Thank you so much. Enjoy the night. Enjoy the day.
Thank you. Bye-bye.
Bye-bye.